My name is Guy Young. I'm the director of the Houston Center at Children's Hospital Los Angeles, a professor of pediatrics at University of Southern California, Keck School of Medicine, and I'd like to welcome you to this video module called Cutting the Weight, Improving Prior Authorization Process for Quicker Approval. Along with me today are Maya Bloomberg. Maya is an advanced practice nurse, a nurse practitioner at the University of Miami School of Medicine Hemophilia Treatment Center, and we have her with us. And in addition to that, we have Mr. James Kenny, president of JT Kenny LLC. Mr. Kenny is the president of the Academy of Managed Care Pharmacy. The learning objective here is to implement strategies to streamline the prior approval and appeals process through improved documentation and enhanced provider-payer communication. And I'm sure you're all aware it's a very important aspect of our care. We want to be able to get the medications into the patient's hands, if you will, and writing a prescription is not the only part. In our healthcare system, we also have to have the payers on board as well. So we're going to discuss that during this module. And so I'm going to turn it over to Mr. Kenny now.
Well, prior authorization is certainly an important management tool that we use at the health plan level to make sure that the appropriate patients are on therapy, and essentially to keep the system balanced as best we can. What we don't want to see is a patient with mild disease on an aggressive treatment paradigm, or a patient with a moderate or severe disease on an inappropriate one. So we try to balance that. And step therapy can be used to drive preferred products based on clinical and economic factors. If products that are therapeutically interchangeable and some are less expensive than others, certainly from a plan perspective, we try to balance that as best we can. We certainly don't have unlimited resources, especially in a category like this, where individual patients can easily be $300,000, $400,000, $500,000 or even higher per year, and patients with inhibitors can exceed $1 million a year in some cases. We also strive to balance pharmacokinetics, sound dosing intervals, so we want to make sure that the patient is being managed and monitored appropriately, and we're getting the best return on investment for those dollars we're expending on the various treatment options.
Great, thank you. So I want to review something that we think about as the provider, sort of thing called step therapy. So, you know, there are many barriers and challenges in terms of putting together the documentation that is needed, dealing with denials, et cetera. And so, you know, there are sort of several steps or layers to this. The barriers and challenges for us as healthcare providers is that it does increase the workload of the staff. So you might prescribe something, get a denial, you then have to do an appeal, you then will have to provide more documentation, which we'll discuss further. It really is time-consuming, and for us as the providers, not such a pleasant experience in general. So this can have real impacts on patient outcomes. Delays in getting a new therapy for a patient, for example, could result in adverse clinical outcomes to that patient if the new therapy is going to be, you know, so much better for them that it can help them to prevent bleeding or get them to administer the factor or whatever treatment might be easier. And prior auth and shared decision making, this is the sort of the balancing act, and ultimately, you know, we may end up with a discussion, and I've done that on many occasions actually, have a discussion with the medical director so that we can collectively make a decision that is obviously best for the patient, which is my most important concern. But with many treatment options out there, you may work with the medical director and find an option that is good for the patient and that also works well for the payer. And I don't think we should dismiss that as an unimportant aspect of the patient's care and ability to get access to care. Let's take a look at the nursing perspective and see how step therapy impacts nursing.
Sure. Well, as you previously mentioned, the step therapy can lead to treatment delays. And a lot of our patients don't necessarily understand the insurance landscape and what it takes and what the process entails, from prescribing a medication, completing the prior authorizations, and what we really do to get these medications approved and essentially paid for. So we do see worsening of the disease. A lot of patients and insurers require failure of different therapies in order to approve a newer therapy. So this is translating to patients requiring a lot of breakthrough bleeds and subsequent joint damage. to get a better therapy available for them. As providers, it's extremely frustrating and stressful to us, so you can imagine the emotional toll that it's taking on these patients. And we can see some patients actually abandoning their treatment. They might be frustrated with the delays and decide to stick with their current regimen, where they're still having a lot of bleeds and have a lot of subsequent complications with that. Or they may become frustrated and just stop being adherent with their therapy options altogether. So as nurses, we need to just have ongoing assessment, ongoing communication with the patients, and really keep them informed with what's going on to try to prevent these things from happening.
So let's discuss a little bit about documentation with respect to trying to obtain or access a new therapy for a patient. So just some background, I had a patient who was having very significant venous access issues. He was on factor prophylaxis, he had a port. To make a long story short, his port wasn't working anymore, we had to take it out. We tried to use venipuncture for him, but it was getting more and more difficult. And he, in fact, started to have bleeds when he wasn't having any bleeds before, simply for the fact that the parents couldn't access the veins at home. So then emicizumab was licensed, but it was only licensed for patients with inhibitors. And this patient of mine did not have an inhibitor. And so when we wrote a prescription, it was denied. And it was denied for the reason that he did not have an inhibitor. And at that point, the license was not for patients without inhibitors. So in spite of us sending a lot of documentation, we demonstrated the fact that bleeding, we demonstrated that he was having serious venous access issues. We even sent them some photos of the patient with lots of Band-Aids on his skin. So we did everything we could to attempt to get emicizumab authorized, albeit off-label at that time, but nevertheless it was denied. So the patient had to continue on his factor therapy, although it wasn't working very well. Ultimately, emicizumab was licensed for patients without inhibitors about a year after it was licensed for patients with inhibitors. And at that point, when we requested an authorization for emicizumab for him, then it was approved. So some of the issues there with the delayed ability to get emicizumab is that the patient started developing issues of medical trauma. Medical trauma is a psychological issue where patients feel either sad or anxious or a combination of those kind of issues as it relates to medical procedures. So this boy was having a lot of anxiety issues because of all the needle pokes he was suffering in order to get factor into his blood to prevent bleeding. And he started having more bleeds, and that led to further medical trauma. So finally, we were able to get him emicizumab, and he stopped bleeding, and he's doing much better. But he still was having medical trauma issues that had to be addressed by our psychologist as a result of that. So that's a case where you look at the situation, and yes, we were trying to obtain a drug that was off-label at the time, but clearly a drug that was demonstrated to be effective in clinical trials for such patients. And this patient ended up, suffering as a result of that. So let's take a look at some other strategies from Ms. Bloomberg.
Sure. So in order to improve our documentation, it'd be nice if a lot of the insurance plans had a universal prior authorization protocol to approve certain medications. But unfortunately, each plan has different requirements and different policies in place for approving factor products and non-factor products. So I think it's extremely helpful to know what the plan requirements are before actually submitting a prior authorization, and that way we can make sure everything is sent in at one time. Adopting a team-based strategy for documentation is really important. So any person who comes in contact with that patient should have some contact. So that's the hematologist, the nurse, the social worker, the physical therapist. I one time was able to get a patient on emicizumab before meeting that plan requirement of failing 3 therapies because my physical therapist note clearly documented the joint status and measurements and showed how he has arthropathy and limited range of motion to his elbows and wrists, preventing him from being able to perform a venipuncture and infusion. So having a lot of providers and building that case is definitely helpful. You can also consider creating different templates or smart phrases depending which medical record system that you use to make sure all necessary information is documented during your clinic notes. Sometimes prior authorizations are denied because you didn't include the severity, something simple like that. So this is one strategy to prevent that. In Florida, more and more insurance companies are requiring treatment logs to be submitted in order to get factor replacement therapy, especially the extended half-life products approved, and they need to be kept for at least 6 months. So trying to have a standardized process to maintaining these treatment logs is important, kind of getting ahead of the program instead of trying to catch up with insurance requirements as they change. So a lot of places are adopting using mobile apps, which allow patients to input their information extremely easily. And these treatment logs can then be exported and emailed to the providers and printed out to be accompanied with the prior authorization. So the best practice, again, is documenting. I'll know if it's not documented, it didn't happen, and the more information, the better. So again, any interim bleeding history, joint assessments, PK labs. So if you have a patient who metabolizes the factor product quickly, this type of information helps justify why a patient might need a higher dosage or increased frequency of infusions, and will ultimately help you get that approved by the insurer.
Okay, thank you. And then, Mr. Kenny, what are some mistakes that providers make, and how can these be addressed, or what advice would you have for improving documentation, from the payer perspective?
Certainly, Maya makes some good points in terms of making sure you document why you might need to use products for specific patients, and certainly an off-label request for a product like emicizumab at $500,000 a year makes the benefit managers quite uncomfortable, because you don't want to see the entire population move to another product strictly based on convenience, obviously being a subcutaneous product, one requiring IV access. That being said, the patients need to be validated. The health plans want to make sure that the prior authorization requirements are met. Each plan does have a unique prior authorization system. Ideally, electronic prior authorizations would help all parties involved. Not all plans have moved to that approach, but that certainly provides the data accurately and can help the providers, get the information in correctly. And to your question, Guy, that specifically is number one reason prior auths are not likely to be approved, is there's some missing information or some missing documentation. But at the end of the day, from the plan's perspective, I think to be appropriate, the criteria have to be fair and reasonable, and ideally we want to avoid any unnecessary risk of hospitalizing a patient or a patient experiencing a joint bleed and further damage to their joints.
Okay, thank you for that. And then going on to back to Ms. Bloomberg about communication, can you discuss what are strategies to improve communication between the provider and the payer? I mean, obviously we are working together, hopefully for a common goal, although sometimes our goals differ with respect to what we are looking for, what we want for our patients, and then how the payers might view things. So how would you suggest discussing communication with a payer?
Yeah, I think you hit the nail on the head, because as providers, we're trying to seek what's best for the patients while the payers are looking at the financial aspect of things. But ultimately, communication is what leads to reimbursement, and the better communication, the easier time we're going to have to expedite these claims. So filing prior authorizations electronically has been very helpful. It's much easier to track these. They usually are processed much faster as compared to having to fax in a prior authorization, and there's less chance of it getting lost. And actually getting lost, or if this is an excuse, but it just definitely helps with tracking. And I know it seems like a no-brainer, but you want to make sure these prior authorizations are complete. If you have a patient missing a date of birth, or the ID number might be off by one number, or even just missing a provider's signature, all of these can lead to delays. And again, we want to become a details person and document everything, because the most common reason for the denials are usually administrative, where the health plan doesn't necessarily have the documentation need to approve the product. And this could be where we're missing information or have incorrect or incomplete information. And then the second reason for the denial is more clinical, where they decide the medication might not be medically necessary. And that's when we're going to touch a little later on this presentation, how to address those type of denials and the appeal process with that.
Okay, thank you. And then Mr. Kenny, from the payer perspective, how can we as providers improve our communication?
Well, certainly from a plan perspective, what we're trying to do is be assured that the patients are being managed appropriately and accurately. Obviously, hemophilia treatment centers are a key strategic option to improve that. They improve communication. They give the health plans a sense that, the patients are being managed appropriately. And then internally at the health plans, case managers play a key role in coordinating with the hemophilia treatment centers and the individual providers, requiring patients to make sure they have regular appointments, and then the additional medical needs they are faced with can be managed quite effectively by the HTC team or the provider team. And that's very important for us to make sure that we're getting overall good management of these patients.
Okay, thank you. And then just looking at the clinical implications of denials, prior auth denials, I mentioned earlier that the consequences could include more bleeds, worse joint outcomes, and obviously this affects the patient and the family emotionally as well. It was quite a trying experience when we were working with that one family to try to get emicizumab for them off-label ahead of time. So, you know, why? What are some of the reasons why, from the payer perspective, why an authorization may be denied? Can we review that, Mr. Kenny?
Okay, so the question here is, you know, why are prior auth denied? And I did mention a couple things earlier. Primary reason is insufficient information. And again, we would hope that as plans move to electronic prior auths, Maya certainly indicated that that's a very helpful tool. And plans and benefit managers clearly have an obligation to provide clear, clinically appropriate prior authorization criteria to effectively match the patients and providers to the right product. And again, although it appears that the plans only desire to manage this from a cost perspective, clearly they need to have the patient's interests at heart. And because it is a very expensive category, you need to apply some degree of management to make sure that we're getting a good return on investment in this population.
Okay, so let's move on to, you know, what's next? What happens after a denial from the provider perspective? So what do we do on our end? What are the strategies to appeal a denial? So first of all, having additional documentation of a poor outcome with the current therapy, that's probably the most important thing. I think that if you can demonstrate, and then clearly demonstrate, as Maya said earlier, with documentation, right? If it's not documented, it didn't happen. So clear documentation from the medical records, from patient diaries, I mean, whatever it is that you have that is, you know, documented, to put that together and to put that into the appeal letter. And the elements would include, obviously, description of the case. What are the limitations of current treatment? Why is the patient not doing well with current treatment? And what are the expected outcomes? What are the expected improved outcomes with a new treatment? And if necessary, providing references from the medical literature can be very helpful in overcoming a denial with that first appeal. So back to the payer perspective, Mr. Kenny, what about how we can improve our documentation, or what are the elements that need to be in there with respect to an appeal to the care plan?
Well, without question, additional documentation is going to be very important to certify why the particular patient needs access to that treatment. That being said, we often will say in our business on the managed care side, we don't want to pay for convenience. So if the request is really focused solely on convenience and there's a significant cost difference, you're likely going to get some resistance from the plan. But if you can document a clinical need in this case for requiring this alternative, then it's likely it will be approved on appeal. So specialty pharmacies can certainly be a valuable resource to providers, as many health plans use them as exclusive distributors of these products to patients in an outpatient setting, because they clearly understand the plan's benefit designs, the requirements for coverage, and may even be able to assist in that process of getting a prior authorization approved or expedited through the process.
Thank you for that. And then let's turn back to Maya and let us know, you know, from your standpoint, you know, as a nurse practitioner, you're very involved in this. How do you go about appealing a denial?
Sure. So you mentioned previously really well what should go into the actual appeal process. So I kind of have a template, which you can see on the right-hand side, on what should be included in that letter that we're sending to the insurance company. So in addition to the patient's information and identifiers and the prior authorization number, you want to make sure you include a description of that denial and the specific reason why they aren't approving the drug. You then want to go into a little depth of the patient's history, what prior therapies they were on and the outcomes, what were the limitations of these outcomes and why we want to switch them on this proposed treatment plan. And then, as you said before, medical literature is really something that has been very impactful and helpful to get these products approved for our patients. Some resources that I recommend people benefiting from is reaching out to the actual drug manufacturers, because they can help you navigate that appeals process. before even sending a prior authorization. They can help do a benefits investigation and try to let you know what the actual plan requirements are for that specific product. And once it's denied, they can help you get the necessary medical literature needed to support its use. And in the past, I used to have to do PubMed searches and find my evidence-based research articles myself. That using this resource, it saves me a lot of time and allows me to focus more on patient care. So I do encourage people to take into account the manufacturers being a helpful aid. And as Dr. Kenny had mentioned, the specialty pharmacies can be very helpful as well.
Okay, thank you. And then, ultimately, if everything fails with respect to appeals and repeated appeals, at that point, a peer-to-peer discussion can be very helpful. And I will tell you, I've definitely had to do that on a number of occasions in the past, where me as the provider would speak to the medical director of the insurance plan, and we would try to together collectively make a decision that is best for the patient, keeping in mind as well the goals of the payer. So, how do you conduct that discussion? Well, two things. First of all, obviously it should be professional. Begging doesn't help. So don't stoop down to begging. And then being, sort of rude or nasty to the medical director and saying, well, you're not a hematologist and you don't know hemophilia and I'm an expert. That doesn't work either. So just keep it professional and keep it fact-based and say, sent the appeal in, you have that in front of you, they should have that in front of them, they should have the history. And then just to, appeal to the nature of the medical director as a physician and to say to them, look, here's the bleed logs and maybe some pictures, like the pictures I sent in before showing venous access issues, reviewing medical references, medical literature, as Maya had just said, discussing the benefits and risks of a novel therapy, and just then having, providing your own professional opinion as to why you think that this other therapy that has been denied is so important to the patient. And then offer, of course, to answer questions. So keep it professional, provide the facts, and then using those facts, give your opinion as to why you think this treatment that has been denied is important. But let's take a look at the other side of things from the payer with respect to peer-to-peer.
Well, certainly peer-to-peer is a challenge because most plans don't have a hematologist on staff in the utilization management department or that medical director, unless you're really lucky and you happen to get one who has a hematology background. It does create a bit of a challenge. And keep in mind, these same medical directors are reviewing appeals across multiple disease areas. So you're absolutely right in terms of a positive attitude. And I think recognizing hemophilia is certainly well known. And if you mention the word inhibitor to the medical director team, they very quickly realize, yes, that's a very expensive and high utilizing population we need to try to do the best to take care of. That being said, in some cases, specialty pharmacies, again, play a key role because they may have hematologists on staff that can help the plan manage that piece of the benefit. And some plans may even choose to use them as part of that appeal or review process.
Okay, thank you. And so to conclude this section, here are our SMART goals. Again, about improving documentation to prevent delays in prior authorization approvals. We've heard the perspective of the providers, both a physician provider, a nurse practitioner provider, and from the payer. And ultimately, I think the key that you heard was having good documentation for even the first prior authorization, particularly for the appeals, to ensure that you're getting for your patients the treatment that you think